Okay, we're good to go.
All right. Hi, everybody. Hi, Dr. Friedman. Glad you could make
Hey.
it. Thank you for adjusting your schedule for us tonight. Um, and Dr. Friedman is a naturopathic physician. He was a instructor, a professor of endocrinology at the University of Bridgeport, and he's the president of Restorative Formulations. He has authored textbooks on endocrinology, healing diabetes, and and you also, did I see somewhere you founded a journal as well?
Yeah, the Journal of Restorative Medicine.
Yes, that's right. All right, so we're really lucky to have you here with us this month and next month to talk about neurodegeneration. And I'll hand the mic over to you.
Hi. Okay, and welcome everybody. Talking from Vermont, and it's been snowing here for days, and it's so snowing right now. All right, so I'm going to start off here. Can you all see my first slide here?
Yes, looks good. Thank you.
Okay. All right. So I'm going to talk about hyperthyroidism and hypothyroidism. And So I want to first start off with in
Now listen, so you know the power of attorney that the sister got, Sally.
Yeah.
hello.
Listen to this. Number 12,
Is there someone
power with respect to entities or forms of ownership or related transfers to create.
hello? Okay.
Sorry, Michael. Why don't you take it from the top? We had some open mics. I took care of the problem.
All right. No problem. Let's see just 1 second. I just if you guys don't might have to open the right PowerPoint here. I don't have the right one. Okay. Okay. Can you guys hear me now?
Yes, I can hear you.
Okay, you see me. Okay. All right. So for thyroid disease, we really have different options. And I want to say that, in conventional medicine, we all were taught that there's only one option. But I think, for example, in hyperthyroidism, it's good to consider that we actually have a restorative approach where we can look at integrative medicine using natural medicine as well. The benefit from that is like anti-thyroid drugs only cure about a third of the patients. And two-thirds of patients, anti-thyroid drugs only work temporarily, and most patients eventually will need radioactive iodine. So there's a solution there for hyperthyroidism with conventional medicine, but it's far from being perfect. One is that most people end up becoming hypothyroid. So if there's any way to prevent people from getting irradiation and keep their thyroid, this is where I think our medicine can shine. And
Michael, did you want to share some slides or
oh, you can't see my slides?
no?
Oh, well, that's a problem.
I gave you ability to screen share. We had it on an older
Okay.
minute or so.
All right,
So
let
see
me
if you
get
can reshare those slides.
okay, screen share. Let me see. Okay. All right, can you see
Okay,
that?
there we go. We got your slides up now.
All right, so I'll start from slideshow. All right, so you guys can see it?
Yes.
All right, great. Uh, so hyperthyroidism, again, it's not a great solution in conventional medicine because most patients need to be will end up becoming hypothyroid. So if there's anything to help prevent this and for patients to be able to keep their thyroid, this will be excellent. And I would say, I'm confident to say that over the years, I've had many hyperthyroid patients and none of them needed radiation. What about hypothyroidism? So hypothyroidism, I would say you also have a choice. You can also add a restored approach by using herbs and nutrition along with the pharmaceuticals to really help patients do well. And here's a study here, 40 to 60% of patients who are on T4 levothyroxine on its own have persistent hypothyroid symptoms despite normal TSH. So here we have two things. We can help with patients with hyperthyroid, and we also can help with patients with hypothyroid, because both treatments are not really satisfactory on their own for most patients. So let's focus more on hypothyroid in the beginning, and then I'll finish off with hyperthyroidism. So in a hypothyroidism, when people are on levothyroxine, persistent symptoms can occur for most of these patients because, one, the conversion of T4 to T3, T3 is the active hormone, can be impaired. Inflammation or autoimmunity can block T3 receptors, and T3 receptors are really, at the end of the day, what's essential for the metabolic system to be reset, because T3 is, for the most part, which stimulates the mitochondria. The mitochondria can remain underpowered, and the TSH does not reflect tissue level thyroid activity. TSH only reflects the level of thyroid hormones in the serum, not actually in the cells itself. And one of the speakers and colleagues I know is retired. He's an endocrinologist. Dr. Cunningham, and he actually practiced medicine before the advent of TSH. And he said, I got to tell you, patients got so much better before we started looking at a TSH, because we looked at people's symptoms. We looked at body temperature, looked at fatigue, depression. We looked at all those different things. And if someone had those symptoms, we used to just give someone a therapeutic trial of thyroid hormones. And he was a big advocate of T3, and he went straight to the active hormone T3. And he said, that's the best way to know if something works. Try it out and see if they respond, not just look at not the number. He said, doctors now are just looking at the number, and they don't really regard what the patient's symptoms are. So Synthroid, also levothyroxine, just a brand name. It normalizes blood levels of hormone, fine in many people, but does not necessarily collect peripheral thyroid hormone receptor sensitivity. It does not improve mitochondrial oxygen utilization. So patients can still feel tired. If someone's on thyroid hormones and they feel totally fine, then you don't really need any more support. But if someone is in the 40 to 60%, which still has some symptoms, this is where natural medicine will really help. I've identified, these are some of the key ingredients which I've used for my patients. So iodine, it's a substrate for hormone synthesis. Also, selenium helps with the conversion of T4 to T3. The herbal myrrh, which is used in incense, and also in the story with the three kings, we use that to burn for incense. But myrrh actually is a resin from a tree, and it also has shown to improve the peripheral thyroid hormone conversion. Also, seaweed, it contains polyphenols, which have also to be anti-inflammatory. It contains iodine, but it also does a lot of other things in terms of supporting the thyroid. So I want to do a picture here of Abraham Hoffer. He's my mentor. He passed away, but he's the father of what we call orthomolecular medicine. He's the first doctor really to start using high doses of vitamins. He's the one who discovered, with the use of niacin, that lowered people's cholesterol. He was a psychiatrist. He treated a lot of schizophrenics, but he also just really started a branch of medicine called orthomolecular medicine, which is using vitamins, which was considered so radical in the 1950s. And I remember he spoke at one of the conferences I put on, and he actually also helped me to treat some of my patients who had cancer. And he used to start off with like, well, you have to tell your patients, are they willing to live longer, and are they willing to feel better? If they answer yes to that, then they should try natural medicine and vitamins, because they will live longer and they will feel better. So in general, I would say a lot of this approach has side benefits and not side effects. And by the way, that's how I actually got into medicine. Was I went to a naturopathic doctor. I was considering regular medicine, but I went to a naturopathic doctor, and I actually got some of I noticed that some of the nutrients they're giving me had side benefits instead of side effects. So let's look at here at iodine. Iodine levels have fallen 50% since the 1970s. Thyroid disorders have skyrocketed since the 1970s. The amount of iodine in most people in the United States are not enough to produce iodolactone. Delta iodolactone is the iodine, which is iodinated to lipids in anywhere where there is the iodine symporter, which was also the breast, the thyroid, salivary glands, prostate, and delta iodolactone is helps decrease proliferation. It helps decrease inflammation. It's a very important compound, delta iodolactone. If you go on ChatGPT or go on whatever PubMed, you can find so much scientific research about how this compound, delta iodolactone, is essential for health. And if you're giving someone iodine for thyroid, you'll also help them in other ways. So here is, look, for example, here is a review: thyroid nodules and goiter. If someone's taking a higher amount of iodine than what's considered normal in the US diet, and you're giving it to patients for hypothyroid, you'll decrease the amount of thyroid nodules and goiter. Definitely fibrocystic breasts. I used to treat patients, I've treated patients with 12 milligrams of iodine a day along with herbs. And we'd noticed that the patient's fibrocystic breasts would go completely back, would have no fibrocystic breast within 2 or 3 weeks of treatment while treating the thyroid. And this is an example: when you're treating one thing, you can have side benefits of other ways. So thyroid nodules and thyroid goiter has definitely gone down with thyroid when you have enough iodine to produce this compound called delta iodolactone, which is extremely low in a North American population, according to the NHANES study. Thyroid cancer and iodine. Iodine sufficiency correlates with lower incidence of follicular thyroid cancer. And the proposed mechanism is delta iodolactone. Again, delta iodolactone is iodinated lipids, which do not form in high enough amounts with the current US diet. Breast cancer and iodine. Here's an article showing that iodine and iodine lipids in the form of production of delta iodolactone contributes to lower breast cancer rates. And look at, for example, in places Japan, Iceland, breast cancer rates are very low compared to the United States. So here is a slide that Anthony Bianco, endocrinologist, made, who spoke with one of my conferences as well. And he runs a research lab in T3, because T3, at the end of the day, as he said, is what actually stimulates the cell. And for example, so an example of why T3 production is so essential: when a baby is born, the neck, the neck isn't held up. And the reason the necks are so floppy is that the nerves are myelinated. And what stimulates that myelin growth is T3. It's not T4. It's the T4 which goes in from the plasma into the cell, which actually stimulates the mitochondria, goes into mRNA production to produce the myelin sheath. So the development of T3 within the cell, which there is no blood test right now to see T3 in the cell. You can only see T3 in the plasma. Most T3 in the cell is actually converted from T4 in any cell which contains deiodinase enzymes. The deiodinase enzymes, which converts to T4 and T3, is found pretty much throughout the body. It's found in the brain. It's found, it's in the liver, the kidneys, primarily in liver and kidneys. And that's why, for example, if someone has liver problems or kidney problems, they will eventually get very cold really quickly because the metabolic rate goes down. T3, which is the active hormone, is essential for growth, metabolism, cognition, brain function. People have brain fog. For example, Lyme disease, some people have just actually given people straight T3 to help with them. Also with premature babies, some endocrinologists have even used T3 to help with premature babies to help them grow their myelin sheath. I've used small amounts of T3 in people with congestive heart failure because the mitochondria has decreased so much that the heart has such a hard time pumping blood anymore, that even a small amount of T3, like 5 micrograms, can make a profound impact. So I want to start here that studies consistently show that physicians' decisions align with what they believe their colleagues are doing, even when evidence is weak. And I spoke, I'll name the doctor as anonymous, I won't mention specifically, but I know the endocrinologist on a personal level who actually decides when someone should treat with thyroid hormones based on TSH. They come out with a range. And he heard me lecture about T3, and he said, my gut feeling is you're right, and that T3 would help. But as an endocrinologist, I can't just say this. We have to prove it in such certain ways that we'll never be able to change the standard of care. But he says, I can completely understand why your patients might do really well when you're giving people these doses of pure T3 liothyronine. So it's just part of the herd instinct. So when using this natural medicine, you have to be somewhat confident in leaving the herd. So this is a product I designed. It contains a lot of these herbs and vitamins that we discussed to help with thyroid. It's not a replacement for thyroid hormones, as the thyroid decreases the production. When someone has Hashimoto's, an autoimmune disease of the thyroid, it creates permanent damage of the thyroid. I've seen the very beginnings where someone just got diagnosed. I've seen some patients get cured, but most patients need thyroid hormones. But someone still on thyroid hormones and tired, giving a product like this or giving ingredients like this will help the T3 conversion of T4 to T3, and people feel better. If after 2 or 3 weeks, these herbs or vitamins are not enough, then it's not working, and it's a very small amount of people, then they need to go straight to the active thyroid hormone T3. So now I'm going to move on to the way I look at hyperthyroidism. So it's essential to treat hyperthyroidism. If someone's in hypothyroidism, you still need to treat, it's essential, but hyperthyroidism can kill something. Well, it can cause mortality, as in one can have tachycardia, atrial fibrillation, severe hypertension. So it's something that you really, before you start treating, you really need to be confident that you're able to control all cardiovascular symptoms and not put anyone at risk. Conventional treatments usually end up with radioactive iodine or thyroidectomy, where they destroy the thyroid gland. Although antithyroid drugs will buy people time, and antithyroid drugs, methimazole, PTU, are actually all originating from actually natural medicine, by the way. They found it when cows ate certain plants, they'd get goiters, and they actually synthetically started making some of these compounds and made PTU drugs out of that information when the cows started getting thyroid goiters. Pretty interesting. And also, I want to say one thing is, in Europe, they have a better success rate in conventional medicine versus the United States. Part of the reason they use antithyroid drugs much longer and are able for more than 18 months and are able to get a higher amount of remission, at least 50%. So a different approach might be better, or maybe combining an approach might be important. I'm not against pharmaceuticals such as using PTU, and I've used them along with herbs, but I've been able to most patients wean off the drug and just be on herbs, and eventually wean off herbs and vitamins as well, to the point where the thyroid hormones are normal. This is true, I would say, for most patients who have minor to moderate hyperthyroidism. More severe hyperthyroidism, I'd want to put on the drug right away as well, like PTU. Again, I've never needed a patient need to go radioactive iodine. So if we can stop hyperthyroidism and we can save the thyroid, we could agree that I think that would be a better solution. But doing this takes courage, as long as a lot of doctors have been very scared to treat hyperthyroidism in regular in family practice unless they're in endocrinology. And part of the herd instinct is, again, everyone will need to get irradiated. It's most people eventually. So based on clinical experience, historical evidence, and some clinical trials, I'll show you why natural medicine is a good solution. And I've used it and it's been effective. So hyperthyroidism, toxic multinodular goiter, toxic thyroid adenomas, and the most common is Graves' disease. So I just recently treated a patient who was a refugee from Sudan. He had toxic multinodular goiter, severely hyperthyroid, and suppressed TSH. And I looked up that in Sudan, people extremely have a lot of goiters due to low iodine. There's so much evidence that toxic multinodular goiter is iodine deficient. We know goiters are usually iodine deficient, has to do with iodine deficiency, but so is toxic multinodular goiter. I gave the patient simply 25 milligrams of iodine twice a day, and he went back to the endocrinologist asymptomatic within 1 week. The most common is Graves' disease, and that's an autoimmune disease. Toxic thyroid adenoma is another one. How common is hyperthyroidism in general? It's about 3 to 5%. The adult population. So Graves is an autoimmune condition, and it's a production of an antibody called thyroid stimulating immunoglobulins. And this actually stimulates the thyroid just as TSH would, and thyroid hormones are overproduced. And the way I know that these herbs work by helping the immune system is that I've seen the TSI, the thyroid stimulating immunoglobulin, completely normalize using herbal medicine. TSI is elevated by 80% of patients, not everybody, and it sometimes can be in Hashimoto's patients. Graves, if you treated it, you'll notice that sometimes it evolves into Hashimoto's and it flips back and forth. But from a natural perspective, I would look at some of the same ingredients to treat both. So what happens to iodine after absorption? So one thing is iodine goes through the symporter called the sodium iodine symporter, where it gets oxidized with hydrogen peroxide and eventually forms, it's called a organification of iodine, and it produces monoiodotyrosine, diiodotyrosine, which is iodine, 2 iodines with a tyrosine, and then diiodotyrosine with 1 more iodine. It produces triiodothyronine, also known as T3 or liothyronine, or 2 diiodotyrosines mixed together produce T4, also known as levothyroxine. When delta iodolactone and other, there's enough of iodine, it produces iodinated lipids, produces delta iodolactone, which is the key mediator of anti-tumor properties of iodine in the thyroid and the breasts. So here, this is what happens in the breast tissue where there's a sodium iodide supporter. And fibrocystic breasts will usually resolve very quickly with taking iodine. Now, another perspective is when someone's taking radioactive iodine, it enters the sodium iodine supporter and destroys the thyroid. But it also enters the ovaries, the salivary glands, and the breast tissue. Radioactive iodine is not the ideal drug if someone can avoid it. It is clear that iodine deficiency may cause hyperthyroidism. Here are all the studies shown that iodine deficiency can be clearly related to hyperthyroidism. Here, women who received iodine supplements were less likely to develop hyperthyroidism. There's 3 trials involving 543 women to show that this was true. And this was in the Cochrane systematic review. So if Cochrane supports this hypothesis, it's going to be hard to argue that there's no evidence, because they're all about evidence. So can you use iodine along with drugs? Absolutely. Iodine actually boosts their effectiveness and decreases the adverse reactions from the pharmaceuticals like PTU because you need less of it. Iodine will not make the problem worse. In Japan, dietary iodine is 3 to 9 milligrams a day. In the United States, it's about 150 micrograms. And there's not a higher incidence of thyroid disease, and some evidence there's actually lower thyroid disease, and certainly less of breast disease cancer. So here's an iodine therapy protocol for hyperthyroidism. I use 6 to 50 milligrams of iodine. I usually find after 7 to 10 days, there's some amelioration of symptoms. And I noticed that the free T4 levels would eventually start dropping. Can iodine alone treat hyperthyroidism? Yes, especially, I would say especially for toxic multinodular goiters, and I've seen it helpful for Graves. But I would say you often need other things as well. Selenium is a very key compound. It shows it increases the glutathione peroxidase, but it also has helped patients in, for example, in studies in even small on its own for subclinical hyperthyroid patients. And some evidence it also helps with ophthalmic symptoms. In general, it also reduces thyroid antibodies, also in both hypo and hyperthyroidism. So these are the herbs which I use in Graves' disease. They're all in the mint family. Bugleweed is a one which has always been considered one of the standard ones. The eclectic physicians, which were MDs at the turn of the century, they used these herbs to treat hyperthyroidism before it became not cool to use herbs. But MDs use these herbs. Here is a study in Germany where they did a lot of study using this herb specifically, and they were able to show a reduction in hormone values, 72%. And 96% retain improvements for 2 years just using this herb. They find it bind with TSI, and that's why I think I've seen the thyroid stimulating immunoglobulins to go down. In this study, Germany, 80% were approved just with this drug or herb. Managing cardiac comorbidities, I could go into that another time, for longer, but there are a lot of herbs, and of course, you need the basis for the pharmaceutical would be a beta blocker, but there's also other herbs like Ralphia, Convalare, which can help with tachycardia and blood pressure. So restorative treatment for hyperthyroidism, we have herbs. Rosmarinic acid is the polyphenol, which is found in plants in the mint family, such as lycopus, bugleweed, lemon balm, etc., which all have shown to decrease thyroid stimulating immunoglobulins. Before I learned about iodine, that's all I used for hyperthyroid patients, and it worked for the majority of patients. But as I've started seeing other speakers talk about how well they treated thyroid disorders, especially hyperthyroidism with iodine itself, I started using iodine as well and selenium, and I think I've gotten much faster results. Here's a product I designed. The higher the dose, the quicker it works. I give patients up to 10 capsules a day, and we guarantee the product. If it does not decrease T3 or T4 levels or does not increase TSH levels, within a few months, we give 100% money back guarantee. So restorative approach to hyperthyroidism. It can provide effective control in many cases. It can save the thyroid in most cases I've seen, and it is less expensive and less intrusive in the big picture. Although I gotta say the herbs are expensive, it usually takes about $300 to $500 to get a hyperthyroid patient back on track using natural medicine. But a hyperthyroid with a drug, it's usually covered by insurance, but it's $2,000 for one little pill, and then they become permanently hypothyroid. So I can encourage you to explore any of these options. And that completes my lecture. If anyone has any questions, I'm fine. You can always email me, michael@restorative.com. And hope you enjoyed the lecture. That's it. Thank you for having me speak, Dr. Sleevey.
Thank you, Michael. I've got a question. You talked about the serology testing, blood testing. What other modalities do you utilize to monitor and manage both hypo and hyperthyroidism?
For hyperthyroidism, I would be looking at TSH. I'd be looking at T3, T4, and thyroid stimulating immunoglobulins. And sometimes the symptoms improve before the blood test. Sometimes TSH takes the longest to start responding. That I've seen it 2 months, 3 months, 5 months. It depends, but the first thing I usually start seeing is the T3 and T4 levels to start going down. But clinically, I would say it's really essential that anyone's blood pressure is under control, and the tachycardia, the high heart rate. If anyone has a heart rate over 100 while resting, to me that's concerning if it's continuous. So I'll be using the herbs, and hopefully that will work. But if it's not enough, then they would need to use a beta blocker. For hypothyroidism, I look at T3. I might look at reverse T3, TSH. But I'm even if TSH levels are normal and T3 levels are normal and T4 levels are normal, if someone has hypothyroid symptoms, I would treat them. So if someone has low basal body temperature, where I would track their temperature, like say 3 times a day for 5 days, and if their temperature is continuously lower than 98 and they have symptoms of hypothyroidism, such as fatigue, depression, insomnia, weight gain, then I would traditionally try to treat them therapeutically, possibly with thyroid hormones like T3 or herbs. I might look at the thyroid peroxidase antibodies, the TPO, as well. I have consistently seen TSI antibodies go down to even normal in hyperthyroidism. In hypothyroidism, the thyroid peroxidase antibodies sometimes don't go down. Often they go down, but I would not say that's the Holy Grail. The Holy Grail is that someone can feel well.
Right, right. I think Dr. Calderwood had a question. He had his hand up.
Yes, I had listened to a lecture by a lady who's written a book on thyroid disease, and I'm not sure I agree with what she said, and I want your opinion. She said you should never get the TSH below the normal range, or that's a malpractice because it leads to osteoporosis. What's your thinking on that?
Yes. So I actually asked that question to Edwin Cunningham, who is an endocrinologist who actually who's said he treated 10,000 patients with T3. He retired, and he said someone who is the evidence of suppressing TSH and causing osteoporosis is more speculative. The only time it's very clear is when someone's hyperthyroid and severely hyperthyroid, when they're producing like 300 to 500 micrograms of T3 endogenously, it will increase bone loss. But if you're just suppressing TSH below the range, I'm not concerned about that, especially if you're getting their energy up because they start exercising more. I don't think there's not that much of it. I think the only study was that if you're TSH suppressed and postmenopausal, there's increased bone loss. So yeah, you could make an argument someone's postmenopausal. There's some argument about that, but I think if you can get them feeling well and started exercising, they're actually going to be way better off. If you're giving a very suppressive dose of where there's no undetectable amounts of TSH for long term, that you have to use your intuition on that. I would say if someone's really feeling well and exercising, I had a patient before who just literally barely could work, and then she just lit up and went back to life on a very high dose of T3, and she started exercising, and for her, every time we lowered the dose, she just wasn't able to work. So I was okay with it, but I did review some bone scans for her, and for her it didn't worsen.
Great. Does on your slide you had for selenium dose you had 200 to 1,000 milligrams, and then after that,
If that it's it if I did I miss that's a mistake. It's micrograms.
thank you.
Yeah, I'm sorry if that came. I that's definitely wrong. It's micrograms.
Michael,
I'm an aggressive dosage person, but not that aggressive.
on the tail of that great question by Dr. Calderwood, I'd like to ask you to comment on T3 use and atrial fibrillation, or maybe a suppressed TSH, and how it relates to AFib.
So, atrial fibrillation can occur when someone gets sustained tachycardia if the T3 levels are very high. So, especially in hyperthyroid patients, that's how some people present and go to the emergency room, is they'll have atrial fibrillation from a very high level of thyroid hormones. And I've seen that in hyperthyroidism. I have seen that with myself. I've seen that also in a colleague who actually used very high doses of T3 in a hypothyroid patient. And I've seen it, even one patient who I've seen one doctor would give a very high dose of like 50 milligrams of iodine to a hypothyroid patient, along with T3, and that person went into atrial fibrillation. So one has to be careful on these very high doses, especially with high doses of T3. I've never seen it with like small doses, like 5 micrograms or 25 micrograms.
What's the rage on the internet now is the use of T2, like 100 to 200 micrograms of T2 to support thyroid health. Do you do that at all in your practice?
I had, I used to actually have it made for me as a supplement with T2 before I knew it was not legal. And I used quite a bit of it. It was pretty cheap. It seemed like it had an effect. So yeah, I would say had an effect where people felt more energy. I still think T3 is the main active hormone, but I would still, I've used it before, and I noticed a positive effect on it in patients who are hypothyroid. And that's the argument of using like desiccated thyroid. It has some T3, it has some T2, and it has some T4. But ultimately, I think you have to use what works. And sometimes one thing works in a patient and doesn't work in another patient. And there's times where I tried this and that, and then at most patients, I didn't use glandulars, but sometimes I use glandulars and it worked better than not. So
I'm going to read some questions that were posted in the chat box from Charlotte. It's, do you have any general recommendations for daily iodine use for euthyroid individual, given the pervasive dietary deficiencies?
Well, I would say a daily continuous dose, I would say it depends on who you talk to, but I would say if you look at people who eat a lot of fish, or like in Japan, they have like 3 to 6. The studies are that the average person who eats a traditional diet in Japan is at least 3 to 6 milligrams of iodine a day. I would say is at least a good amount, which you can take continuously.
Right. Gail asks if you should take iodine on an empty stomach.
I don't think it really matters that much that I know of.
Okay. Claire asks, how long do you give a patient thyroid PX or thyroid, I guess, calm or thyroid care, she wrote, but I think it's thyroid calm.
Yeah. So thyroid calm, I give it to a patient, maybe with some iodine, possibly, until they're asymptomatic, and this for hyperthyroidism. For mild it can be as fast as 2 months. It can be as slow as, I would say the most I've seen is a year before someone has normal blood tests. And then when someone's normal and they've been well for at least a month or two, then I take them off. The only issue with it, keeping them on, is really it's expensive to make. So it's an expensive product, but there's no side effects from it. So I would certainly, but most people are able to stop it, I'd say after 4 months. and maintain. But sometimes, like all autoimmune diseases, like it's still a chronic disease and it still can come back. So to prevent it, I usually tell people just to like take one bottle once a year just to make sure it doesn't come back. But I've talked to some patients who said, they've been asymptomatic for about 5 years, 8 years. For hypothyroidism, I would say I see it where I see a lot of MDs use is they'll just give patients levothyroxine and they just add thyroid PX and just give people 1 cap twice a day along with the levothyroxine until they feel really well. And some people are able to stay feeling well when they get off of it. And some people start feeling a little more groggy and tired again when they stop it. So it's really ultimately until the person feels well. And if they feel well, then I just keep them on it. And if they want to get off it, and they can try and see if they still feel good.
Very good. I think Kaisha Perry had a question, it's like a case, the 85-year-old female on 25 mics of levothyroxine with labs as the follows: free T4 at 2, TSH at 0.218, and a reverse T3 of 108, and a free T3 of 1.6.
So the TSH is suppressed.
TSH is suppressed and they're pretty high reverse with
Right.
a moderately low free T3.
I would say, aging itself increases reverse T3. I'd like to know how the patient feels. I'd be okay with that suppressed TSH if the patient's feeling well, but I would try giving them herbs, like which I mentioned in Thyroid PX, or if you want to use your own things like myrrh and using selenium to help with the conversion, I would do that. If someone is in their 80s, I usually don't increase the thyroid hormones too much. I'm more concerned about cardiac issues if someone's at a 70 plus.
Further comments that this patient has terrible bone pain.
Yeah, I don't know how that would be related, but if they're, I don't know how big this person is, but I mean, maybe if the TSH is,
you asked me to call you Michael Friedman.
If the TSH is completely suppressed, I would consider just like stop lowering the dose of thyroid hormones and giving them herbs instead, and see how they respond.
Okay.
I'm not saying I'm right, but that's something I would try,
All right. We have David Calderwood again asks, when you use thyroid hormones in treatment, what form are you using? Compounded, murmur, or other?
I used to own, well, I'm not practicing right now, but traditionally I used a sustained release T3, which would be compounded. But then I started hearing other endocrinologists doing it other ways, where they just used pure cytomel, liothyronine, and it didn't come in like 25 microgram tablets and 5 microgram tablets, and it's really cheaper for the patient, and I dosed it differently when Dr. Cunningham, the endocrinologist, told me about how he dosed it and how he learned about using liothyronine or cytomel, which is the brand name, literally in the 1950s. And he says you give someone who's hypothyroid or someone who has hypothyroid symptoms, he would gradually increase the T3 by itself at a very slower rate than I did before. And he said, I've barely ever had any problems with heart palpitations. So his protocol was start off with get a 25 microgram tablet of cytomel, and then break it in half and just take half of that once a day for week 1. And week 2, take half of it in the morning and half of it in the evening, and keep on going in that direction where you use, and he said most patients just gradually every week go a higher increment in the morning, and the week after that higher increment the evening, and eventually you would get up to like 25 micrograms twice a day. And he said about 50% of patients would feel well on that dose. And he said a certain percentage of people didn't quite get the energy he wanted, and then he would cycle them up to a maximum of like 75 micrograms in total in a day.
Okay.
But he always, if someone ever had a heart rate going above 100 resting, he'd never cycle up. And patients need to feel better within the 3 or 4 weeks.
Understand. Okay. Margaret asks, what can increase the free T4 levels that are not responding to levothyroxine in Hashimoto's patients?
So if someone's taking thyroid hormones and it's not increasing the free T4
Right.
versus the total T4.
That was the form of the
Question.
question.
Right.
Yeah, how to increase the free T4.
Well, I'd be more interested in increasing the free T3, but the free I mean, the T4 can be bound up with other hormone like a sex binding globulin, so it might be decreased if someone's on hormone on like a bioidentical hormones, for example. But I would say you'd have to just give a higher dose if they're not getting what you want T4.
And we have a question from Susan Pepper that says, any opinion on hypothyroid patient wants to take desiccated thyroid, can't tolerate it because of severe bladder pain on any type of thyroid medication, even microdosing different desiccated thyroid meds. Why would this happen with these thyroid medications irritating the bladder?
I don't know why.
Yeah, I've never seen that, but
I don't know why, but I can say that sometimes like I've seen so many people associate one thing with another thing that I don't think it's always necessarily objectively true, but they might associate with that. That's a possibility, but I don't know. They could try something else. I mean, they could try just pure T3 or T4 or herbs and see how it responds.
Another question, do you agree to check a TSI level when there is elevated free T4 and free T3? And also, you stated iodine will help with this, such as iodoral.
Okay, so let me ask the first question. So TSI, I'll only look at TSI if someone has documented Graves' disease. So if someone has Graves' disease and they're hyperthyroid, it's going to be interesting to me that their TSI antibodies go back to normal. That would not be found in toxic multinodular, but in Graves' disease.
Right.
And in terms of iodoral, yes, honestly, any iodine is fine. There was an idea that because it's a long story, but I mean the basic bottom line is that iodine in a capsule is all iodide, and we've tested that, and many labs have tested it, and even if you pour pure iodine, it converts to I2 and to iodide. So iodoral used to have the thing is that it has this and that, but when it was tested at the labs, it was found that it ended up being pure iodide. The only way you can still have iodine and iodide, you can have some iodine if in a Lugol solution in liquid, but in a powder, it oxidizes too quick. And it was a chemist which came up with that concept. It was like, how can that be? And then so it was sent to the lab, and we were not able to find it. So.
And David asks if the PowerPoint could be made available to us, like the slide deck.
Sure. I got to make sure it says micrograms though.
Okay. All right. I'll let Stephanie work with you on that to get that
Okay.
PDF file, and we'll post it when we post this recording of this lecture. But we are getting close to an hour, so I don't think there are any further questions I see.
All right.
So I think we'll close out now. Michael, it was great having you back again, and looking
Thank you.
forward to another lecture coming up in a month or so, I believe. And we appreciate it. It's very informative.
Thank you. Have a good day, everybody. Good night.
Thanks, everyone.
Good night, all.
Merry Christmas.
Yeah, Merry Christmas.